Hello and welcome all of you. I'm Dr. Ankit, your faculty of anatomy in our LN Next, and this session over here is a recall session. So we had our exam of FMGE on 30th of July, and there's a recall session of the subject anatomy. So first of all, big relief for all of you, and I wish you all the best so that you score 150 plus and you clear this exam. Second thing is a big relief, and these sessions have dual benefits, minimum dual benefits. For example, if you have already given the exam, you'll be able to see what questions you did right or wrong. That's the part, because that nothing can be done now, but still you have some topics because the fight has not yet ended. You'll be giving further exams after this, so you will have to know and recall all these topics that you have to prepare for future exams also. So that is one benefit. The second benefit are for your juniors who are going to give the exams, because they will be knowing what are the important topics and what are the questions that have been asked and which ways they are asking, and how the things are changing with each passing year. So these are the benefits, and again I wish you all the best. So just relax and enjoy the session. And this is our anatomy subject, and these are all the recalls given by many students who gave the exams. Let's start with the session over here. The first question which came from the anatomy side was after vaginal delivery, a female presented with pain on the anterolateral aspect of the thigh. Which nerve was injured? Now see, if you look at all the previous sessions which we have done, our our LNX main video lectures or rapid revision, or even the offline classes which we have done, or even just before the exams we had various YouTube sessions on ABKI BAAR 200 PAAR. You will realize that name ABKI BAAR 200 PAAR was not just a gimmick, because if you go through all those questions, it would have been really easy to clear the exam with at least 200 plus questions. So we'll see, we'll be showing you some screenshots where we have done, and we have recorded various questions and topics. So if you go through all the videos and go through all the previous YouTube sessions recently before the exam, you'll realize that most of the topics were from those sessions only. So that's a good thing, and that is part that tells you that okay, we keep on revising the main videos and other sessions. Most of the questions will be cleared. So let's see about this question now. So after delivery, the lady had a pain in the anterolateral aspect of the thigh. Which nerve was injured? It was various times they have asked. It's a PYQ previous year question. पहले भी बहुत बार पूछ चुके हैं. And the disease we all should be knowing. The disease name is our meralgia paresthetica, right? What we normally call it as meralgia paresthetica. Right? Involvement of which nerve? Involvement of the nerve that is our lateral cutaneous nerve of thigh. Right? How is it involved? Understand that also. See, this nerve over here, it lies around 1 centimeter in proximity to a very important bony landmark, that is our anterior superior iliac spine. And as this nerve is a cutaneous nerve, so it is lying close to the skin and close to the bone also, because you can feel this ASIS. So after delivery, or after any operations, or after even muscular hypertrophy, this nerve can be easily, this compressed between the bone or the inguinal ligament at that area. Therefore, when this nerve is compressed or irritated, it will lead to pain on the anterolateral part of the thigh, because there is where this nerve is going actually. This disease is known as our meralgia paresthetica, right? And see, they have asked this question, so remember in futures for the juniors, the questions can be, where is this nerve coming from? Understand this. So this nerve is actually coming from the lumbar plexus. This nerve is coming from the lumbar plexus, right? Its root value is around L2, L3. Its root value is around L2, L3. These all have been discussed. Let me show you an image over here. This is a cadaveric image, and here the muscles are being shown, basically the anterior part of the thigh. And if we trace it over here, and see this is the medial border of the sartorius muscle, that is medial border of adductor longus, that is the inguinal ligament. So this region over here, this region is known as the femoral triangle, right? Femoral triangle. And where would this nerve be? This nerve which we are discussing, the lateral cutaneous nerve of thigh, it is running close around over here and entering into the lateral part of the thigh. Now it is very close to the skin and close to the bone also. Which bone? Anterior superior iliac spine, which will be over here. Because this ASIS over here gives rise to the muscle. That muscle is sartorius. Understand this part. Therefore, this nerve can easily be damaged. Now, this whole femoral triangle anatomy itself is very important that we have covered. Let me show you an image over here where we discussed this question just few days back before the exams in our various sessions, right? In our YouTube channels also, LNX YouTube channel also, we have discussed. You can see this question, and again, this question we have discussed, and by God's grace or by luck, that has been asked like this only in a different way, but yeah, the questions, the topics that we have discussed. Okay, so can have a look at this also. So after this question, and the question that came from the histology part, a very good question, very old question, a very evergreen question. This esophagus does not have which of the following histological layers? And the options over here were mucosa, submucosa, muscle, and serosa. So see, we all know histologically esophagus is a part of the gut. Which part of gut? It is a part of foregut. Gut has 4 layers. What are the 4 layers of gut? Very basics, which you did in all our video lectures. From inside to outside, if you go from inside the lumen to outside, what will we be having over here? Inside always you have the mucosa, right? Mucosa can have different linings. Normally it is columnar epithelium, but in esophagus it has stratified squamous non-keratinized. But in the main part of the gut, the small intestines and the stomach, we have the columnar. So we have a mucosa, and then we have the supporting layer known as submucosa, the loose connective tissue. Then we have what is the role of this? Mucosa will have all the epithelium, right? So it will have the muscularis mucosa, it will have the lamina propria. Some mucosa will have all the vessels, the connective tissue. Outside this, for aiding peristalsis, we have the muscle layer. We have the muscle layer basically, and in the gut we have the mnemonic that is known as ICOL, inner circular outer longitudinal. But in esophagus, it's a bit tricky. Upper part of the esophagus will have more of a skeletal muscles, right? Lower part of the esophagus will have more of smooth muscles. In between, the middle part of the esophagus has some sort of mixed muscles, but that is fine. That is understandable. Then, on the outer part, as we reach in the gut, I'm talking of gut, we have serosa or we have adventitia. Now, what is the meaning of it? See, adventitia is nothing. It is just adventitia is just a loose connective tissue which is covering the layer or the gut from outside, where it merges with the fascia outside the gut. That is adventitia. But when that adventitia is spatialized, when it has the peritoneum, then we call it as the serosa. Right? So this serosa will be found in all those organs which are basically intraperitoneal. That also we have discussed in our lectures. Therefore, this serosa layer is not present in esophagus because the majority part of the esophagus is lying in thorax, cervical part, and the small part lies in abdomen, and it does not have the peritoneal or the visceral peritoneal layer covering it. Therefore, this is the layer that is actually absent in esophagus, and that is what they have asked. A beautiful old question, a very important question that has been keeping on coming in from our histological question. And here's an image of the histology for the esophagus. This is a cut section, the mesenteriform stain. Here we can see few things. What are these? You can see this irregular lumen of the esophagus. Now, why there is irregular lumen? Esophagus normally is collapsed. Normally it is collapsed. When you swallow anything, when you swallow a liquid or a food particle or a semi-solid particle, then it starts to dilate. And therefore, in front of esophagus, what we have? Trachea. So if you take a cut section like this, anteriorly you will have the tracheal rings. This is the anterior part, that is the posterior part. And behind what you have? Behind you have this collapsed esophagus. And behind the trachea or the posterior part of the trachea, we have this muscle over here known as the trachealis. We have this trachealis muscle. These are the cartilages of trachea. The C-shaped ring cartilages of trachea, and this would be our collapsed esophagus. Collapse. Now, when anyone swallows anything, then this esophagus obviously will start to dilate, and therefore it will put pressure anteriorly as well, because behind we have this vertebrae. So therefore, it is this anatomy over here that the tracheal rings, the cartilage is not complete ring of cartilage, it is only C-shaped anteriorly. Behind you have a trachealis. Now this will be pushed by the posteriorly dilated esophagus anteriorly. Right? Therefore, we have this collapsed lumen. Now, if you just zoom it a bit, we'll see a few things over here. This is epithelium over here. Now, this epithelium over here will be always remember stratified squamous, non-keratinized. Then, sir, why not columnar? Because it is when you swallow the food will have some friction onto that food pipe. So you need some protection. You need a stratified layer. Therefore, we have this. Then what do you see over here? This is the part that is the mucosal part. That is the M4 mucosal part, which will have a bit of lamina propria and a small bit of muscularis mucosae as well as over here. Then we have this area, if I put with the red color, this area being the submucosa part, which is actually connected tissue and it's quite strong in esophagus. It is actually protecting the mucosal layer. It is having the vessels, it is having the nerves, it is having the lymphatics, it is having all the fibroblasts, all the connective tissue over there. So it is surrounding the mucosa. Outside it, you have this thick layer that is the muscle layer. Now, why do we need muscle? For peristalsis, for movement. Suppose you are lying on you have swallowed anything, that normally food passes down through the esophagus without the aid of gravity also, due to these muscles, right? So you have these muscles outside, then outside this layer should have serosa if it was a totally intraperitoneal. But here we have, in place of it, we have simple adventitial layer over here. And that is what they ask. Histology of the esophagus, a simple question. Right, so remember, for all those who have given the exams, be happy if you have marked the serosa, and I hope that all of you have marked it. And for all the juniors, it's a good learning curve for you, right? Let's see then the question which they asked. So, patient presented with RTS road traffic accident. On investigation, EDH was found. EDH is our epidural or extradural hemorrhage. Epidural hemorrhage over here, epidural hematoma. So, epidural hematoma or hemorrhage was found. Which part of the skull was fractured? It's a very, very famous question. It is one of those evergreen questions which always, if you see the last 5 years, out of 4 times they have asked. So we all know that epidural hematoma, the main artery involved or the main vessel involved for here is the rupture of the middle meningeal. Which vessel it is? It is the middle meningeal artery. And which branch of it? Basically the anterior division of it. Right, and this artery is itself a branch of the maxillary artery, which is itself a branch of external carotid artery. I hope some students said the branches were also asked, EC or IC. So remember that too. So middle meningeal artery, anterior division gets damaged in epidural. Now where is this located? It is for the meninges. Meninges are inside the skull. So it is basically present inside the skull. Now which part of the skull? That part of the skull is known as the pterion, that I hope we all are aware of. This is a very important part. Now, if you also be looking at the other lectures, main videos, or even the clinical videos, you will realize that we have pointed out this area, how to look for this area. It is somewhat around, you say 2 to 3 centimeter behind the frontozygomatic suture and 1 to 1.5 centimeter above it. This area over here, that is the area for pterion. It is actually nothing but H-shaped area or H-shaped sutures, because there are few bones which come over here that we'll see. So basically, this question was all about asking you about the pterion. That is what it is. Nasion is anterior, leanion is posterior, asterior is on the lateral side behind. This is what they ask about the pterion. So what, remember this pterion H-shaped suture, we'll look at the image. The vessel is anterior division of middle meningeal, which is itself a branch of maxillary artery. That is a branch of external carotid artery. And here you need to do a management, have to be a craniotomy, because it's an arterial bleed. It's acute bleed. It's going to compress the brain. So you need to do a craniotomy. You need to remove the clot and the blood from there to decrease the pressure which is being applied on the brain. And here is this image over here. If you look at this image over here, this is showing us, very important over here, showing us the frontozygomatic suture. This is FZ suture, which you can actually palpate. This is the frontal bone, this is zygomatic bone over here. Here, if you feel the suture, this is the frontozygomatic suture. So if you go behind it around 2 to 3 centimeter at this point and around 1 to 2 centimeter above it, this area is the area of the pterion. Now, what are the bones over here? Understand the name of the bones: the frontal bone, the parietal, the temporal, and the greater wing of the sphenoid bone over here. These bones, they meet and they form this H-shaped suture over here. This part of the skull is thin. Why? Because it is covered by temporal fascia. So inside the bone is actually thin and it's lying on the lateral outside. So any injury over here can damage this bone. And if it damages, if it fractures, the part of the bony spicules that will go deep inside you have this artery, and this artery, as you can very well see over here, this is the anterior division of the middle meningeal artery. Anterior division of the middle meningeal artery. And if they may ask you also that this artery is entering the skull from where? This artery should be entering the skull from which foramen? Then this foramen also you should be knowing it. The foramen from which it is entering is basically the foramen spinosum. Right? Now, damage to this artery will lead to bleeding, and then you have the CT scan image, and you have this image which is actually biconvex shadow. It is actually biconvex shadow. CT scan image, biconvex shadow, extraaxial hematoma. That tells you this epidural hemorrhage. And normally these hemorrhages, they don't cross the sutures. That also an important point to remember. They do not cross the sutures. Why so? The reason is they are above the dura. And dura has layers which are endosteal and the meningeal layer. So if we just go a bit deep into the layers over here, understand, suppose this is the one bone of a skull and this is the second bone of a skull, with between you have the sutures, right? Now try to understand, this will be the endosteal layer of the dura mater. This will be the endosteal layer of dura mater. Deep to it, what we have the meningeal layer of dura mater. This is the meningeal layer of dura mater. Now this bleeding over here is occurring where? This bleeding over here is occurring at this point, epidural, at this point. Therefore, when this bleeding will occur, it will enlarge, but it won't pass through the suture line because the endosteal is fused with the periosteal, or you can with the sutural ligaments. Because here you have the sutures and this will be the sutural ligaments, and this endosteal layer is actually fused to the sutural ligament. So this bleeding normally does not cross sutures, therefore the shape becomes like this. Understand this part, right? So that was the question, and we have done it previously also. Have a look at this. Just few days before the exam, we discussed about the question again, the PYQ. This is a proof of why this was the PYQ. You can see the artery over here. We have discussed the stereon also over here. We have discussed this EDH. Everything was discussed already. Well, this is our normally asked questions. So just to prove that if you go through all the LNX channels and the lectures and the videos, you are sure to get benefited. Next question over here. Identify the image over here. Let me tell you, around 2 to 3 years back, they have asked this in NEET PG also. You look at the PYQs in our app, you will understand it. What is it? You can see the swelling over here in the anterior part of the arm. It is basically due to the biceps brachii muscle rupture, and the sign is normally known as a Popey's sign. Popey's sign is a famous cartoon figure, right? So the biceps muscle rupture or the biceps brachii muscle tendon ruptures, the muscle will actually retract back and it forms a swelling over here. This is what is Popey's sign, right? Biceps muscle. Now see, they have asked this. So you know, in anatomy, they can ask you about the various muscles in the front of arm. They can ask you relevant questions in futures, like what? What is the nerve supplying it? The nerve supplying it is musculocutaneous nerve. If you know this, very good. If you don't know this, then also it's very good because you know it now, right? So nerve supplying this muscle is musculocutaneous nerve. This nerve is basically supplying all the muscles of the anterior arm. Humeral shaft fracture, not having. Tennis, what is tennis elbow? Tennis elbow, you all must have heard about in our India, we have the great cricketer Sachin Tendulkar. Around 2004 or 5, if I'm not wrong. Now, that time he had this problem, tennis elbow. It is about the lateral epicondylitis, swelling in the lateral epicondyle, the muscle tendons which are attached over here, lateral epicondylitis, right? They can ask you about tennis elbow as well as in future. So what is the main muscle involved over there? The main muscle tendon involved is ECRB. Others are also involved. The main is this. Tennis elbow can be asked. Radial nerve injury is a very common question. I guess there was another question on the radial nerve injury that also we have done. There was, I guess, a mid-shaft fracture of humerus, and which nerve or which structure was damaged was the question that was asked, right? Again, radial nerve injury, right? So these are all the questions that have come, and I'm very happy to see the questions actually. And if you also know, if you have revised, then you'll go through it. Now this image over here is showing us the biceps muscles. Now look over here. These are the two heads of biceps. The one on the outer side, that is the long head, and on the inner side is the short head of biceps muscle, and you can see the tendon. Where does the tendon insert also? That is also a question. On which bone? Is this radius or ulna? The answer over here will be the bone radius. The biceps tendon basically inserts onto the radius bone, and this is the reason why the biceps muscle action, if we talk about, it is also involved in supination, because it is the radius bone that moves in supination, pronation, not the ulna. This tells us, right? And if you look over here, when you cut the biceps muscle, deep inside the muscle that you see is the brachialis. This is the deeper lying muscle, and there's the cut end of the biceps. Brachialis over there is going to the ulna, therefore it is not involved in supination, pronation, but it is a deep muscle. It is a very huge, thick, and a very powerful muscle. It is a main flexor of forearm. Again, it will supplied by which nerve? The nerve over here will be this nerve that is going down like this. Now, which nerve is this? This nerve is your musculocutaneous nerve. So this nerve is the musculocutaneous nerve. See? Okay, so this was a question, and I hope you marked it correct. Let's see what else was asked. Again, one of the favorite topics for FMGE is our perineal pouches and the urethral rupture, and again they have asked this. A person had an RT and reported an emergency. He suffered from injury to which urethra? Bulbar part of urethra. Now this should strike your mind. We are dealing with which part of the perineum. This bulbar urethra isn't where. We have different parts of urethra, anterior, posterior urethras. This bulbar urethra basically in the anterior part of urethra, and therefore it lies closer to the skin below the perineal membrane. We are dealing with injury to the superficial perineal pouch according to the question. This is also bulbar part of urethra is one of the most common areas of urethra that will be ruptured. That should strike your mind, your basic revision. Now the question was, what can be the location of the collection of urine due to this injury? So we have an injury in the superficial perineal pouch part of the urethra, that is the bulbar part of urethra. So the urine will start to collect where? In the superficial perineal pouch. It doesn't go into two main places. If you remember, we have discussed many times in our lectures. It doesn't go to two main places. What are those two main places? Those two main places are, it will not go into the istioanal fossa or istiorectal fossa. It will not go into the thigh because of the anatomical reasons. The reasons were Holden's line for the thigh and fusion of Colles fascia with the perineal membrane for the ischial fossa. So it will not go over there. Where will it go? It will go to superficial pouch. It will go to the, it can go to the anti-abdominal wall because it is lying superficial to the scar pass fascia, right? So it can go anywhere, but not to these two places. They are asking you what can be the location of collection of urine. Let us see the options. Inguinal pouch, not too deep perineal pouch, because deep perineal pouch is lying above, so superficial. Peritoneal, it is not an intraperitoneal bleed. It won't go into the inside the cavity. It can't go inside. Anti-abdominal wall, yes, it will go definitely to anti-abdominal wall, no doubt about it. Again, ischiorectal fossa, it won't go. Let us just look at a couple of images to see the differences over here. See, this is the pelvis shown over here, the bladder over here, and this is the urethra over here, right? And this over here, urethra, which is different parts. So this structure which is lying over here known as perineal membrane, right? This separates the perineum into superficial and deep perineal pouches. Like you'll see in the another image, the parts of urethra over here. Now see over here, these are all the parts of male urethra. Now see over here, again you have a bladder over here. Bladder is not shown, there's a lower limit of bladder is shown. Below the bladder, prostate, right? And therefore this part of the urethra is the prostatic part of the urethra, P. This small part is the membranous part of urethra, M, and these P and M are basically the parts of posterior urethra. Posterior urethra, right? And therefore below the membranous part of urethra, if I put a dotted line over here to represent what, which membrane? The perineal membrane. So this structure over here will be the perineal membrane. And below the perineal membrane, we have the superficial perineal pouch. Above it, we have the deep perineal pouch. Bulbar urethra, you can see this bulb of penis. So this is the area where there could have been some bleeding over from here. Some bleeding would have been occurred from here. And this is from where the blood and the urine would have come out. And therefore, it would have collected where? In the superficial perineal pouch. And therefore, also understand that this will go above also because there is more collection over here. It will go into the scrotal layers. Around the penis also it can go. Then it can go in the anti-abdominal wall deep to scar pass fascia. It can even reach up till the axilla. So that scar pass fascia is throughout into the upper part of abdomen also. It can up till reach the axilla as well in rare cases. So therefore understand the two perineal pouches, frequently asked question, the frequently asked topic, and answer over here is the anti-abdominal wall over here, right? Let's see the next question over here. Again, repeated question. If you have doing the last 3-4 years of PYQs, this question you should easily sort it out. A person had the extraction of the third molar tooth, and after this the patient observed to have loss of sensation. Loss of sensation from where? From the entire 2/3 of the tongue and floor of the mouth. Okay, loss of, now which type of sensation they have not said, but they're saying loss of sensation. So we can assume loss of all the sensation, pain, touch, temperature, all of it, and the floor of mouth. Which nerve is most likely to be damaged? So there was the extraction of which tooth? Third molar tooth. And therefore, obviously, there is some nerve damage. They're asking you which nerve damage it is. They're also giving you reasons over here, right? So just few years back, again, a question came. At that time, let me tell you, the PYQ, the question was, surgery was being done on the submandibular gland and its duct, right? Which nerve is damaged? That in that case, also the answer was same. Again, over here, the answer will be our lingual nerve. So here there are few hints. What are the few hints? One hint is, okay, do you know that which nerve supplies anterior 2/3 of the tongue sensory supply? General sensation is given by the lingual nerve, and the taste sensation is given by the chorda tympani. Chorda tympani nerve, which is a branch of facial, and this is a branch of mandibular division of tricep, right? So both are different, but anatomically, this chorda tympani nerve is very, very thin. This chorda tympani nerve is very, very thin, and it is basically being carried by the lingual nerve. This chorda tympani nerve is very, very thin, and basically it is carried by it. So we can assume over here, we can understand over here that if the lingual nerve is damaged over here, then both the, obviously lingual nerve will be damaged, but this chorda tympani also will be damaged, right? And they are providing sensation to the anterior part of the tongue. And this lingual nerve, as it is running, it is very close to the third molar tooth. Therefore, the answer is our lingual nerve over here, not the hypoglossal, not the axillary, not the inferior alveolar nerve. Let's see an image over here. Over here, you can see this is the lingual nerve. They are not showing, but the chorda tympani is running with it in a common sheath. And below, you have this as the hypoglossal nerve. And the question which a previous year question came was this, about this, and this time they gave you about the third molar tooth. Again, third molar will be close to the mandibular foramen behind, and therefore behind we have the lingual nerve that is running, right? Again, a branch of V3. and we also have the hypoglossal nerve and the inferior alveolar nerve, which is slightly above. So basically, for the dentist, they have to anesthetize the inferior alveolar nerve. If you have to do any any procedure on the teeth of the lower jaw, you have to anesthetize the inferior alveolar nerve, because that is sensory to all the teeth and gums of the lower jaw. So you put an anesthesia solution behind third molar tooth. If you have gone to the dentist, you might be knowing it. And when you put anesthesia over there, anesthesia fluid around it, our lingual nerve is also anesthetized. So even the tongue sensations are also lost. In the anterior part of the tongue, the lower jaw teeth sensations are also lost. That is the reason we have this. So in the question, they have given two things, third molar and this. Both of them, if you combine them clinically, answer comes out to be lingual nerve. Beautiful question, right? Let us see this question. Again, a very old PYQ, very repeated, very practical question. If you have done your duties in any hospitals, in medicine or TB chest ward, you'll be knowing it. Or even if you have watched any of the lectures on thorax, a needle has to be inserted by an intern. What is the most preferred site for this clinical procedure? I mean, the language of the question would have been slightly different here and there. But obviously, suppose you have to take the fluid from the cavity, right? There is some this pneumothorax or hemothorax or hydrothorax or any dural abscess there, you have to drain it out. So you insert a needle. Where will insert, in which part of the rib? The lower part of the rib or the upper body of the rib? Where will you go? Obviously, you should not go to the lower body of the rib, because here you have what? Here you have the costal groove, and this costal groove is having what? It is having these intercostal nerve and vessels. The arrangement also has been asked: vein, artery, nerve in this format from top to bottom. So obviously you can't go at the, you should always go to the upper border of the lower rib. So if there is this, there are two ribs, imagine this is rib 1 and rib 2, or let us say some other logical number, let us say rib 4, rib 5. And therefore the needle has to have entered at this location. This location the needle should enter. Why? Because deep to it, this area we have the vein, artery and nerve. So if you insert the needle over here, these structures can be damaged. Let us see this image over here. These are the two ribs which are shown. This is rib 1, this is rib 2. You can see this intercostal structures over here. So obviously if you insert the needle at this point, you can damage these structures. I mean, there are good chances that the structure might be damaged. They might not be damaged also, but why take the risk? Therefore, obviously go at this, not at this point. That was the question that they asked. Obviously, if that was not the option, you can think of going at the middle of the spaces and also, but obviously don't go at the lower border of the rib. Always prefer to go at the upper border of the lower rib. That is a famous question, right? Okay, let's come to end the question. What is the vertebral level for the red colored line as shown in the image? So this sort of image that we got, I mean, exact image might be a bit different, but actually the image was over here at this point. You can see this red line. The numbers are written over here because I hope the numbers were not written, because already then the answer would be self-sufficient. But if you look at this line over here, there are a few planes which are located over. What are those few planes? Let me highlight over here. This line, let us say plane number A, and this line, let us call it as plane number B. Now, if you feel the anterior superior iliac spine, just behind it, around 4 to 5 centimeters behind it, you feel a thickening. That is a tubercle of iliac crest. If you join two on both sides of tubercles, imaginary plane, that becomes a transtubercular plane. Which plane? Becomes a transtubercular plane. That is around L5 or L4, L5 as it's seen over here. That was the line that was asked in the exam. And the second part that can be asked in the future exams is, highest point of iliac crest will be this point B, that is also known as supracristal plane, also known as Staffius line. This passes around L4. Now, where is it used? To whenever lumbar puncture is being done. Whenever lumbar puncture is being done, you flex the patient either in a sitting position or lying down lateral position. You feel the highest point of iliac crest. That is around L4. So these are over here. So if you look at the options, obviously options were confusing, no doubt about it. But here, best bet, we can go with this option L4, L5, transtubercular plane. One of the planes involved when we divide the abdomen area into the regions or the quadrants, right? This transtubercular plane is over here. Other planes also there. There's transpyloric plane, there is subcostal plane. So let us just go through a bit. The transpyloric plane that goes around L1, L2 junction. The subcostal plane that goes around L3. What is subcostal? The lower border of the costal margin. Then we have the supracristal plane, upper part of the highest point of iliac crest around L4, and the transtubercular plane around L5, or you can say L4, L5 junction. That was actually being asked over here, right? So again, a very famous old question, but a very practical question. This is a very practical question that is over here. Again, an old question. A maid complaint of pain and swelling at the knee. Which bursa can be affected in this case? Now, sort of image must have been given to you, or if not, then you should be knowing what they are dealing with. They are dealing with the housemaid's knee. Obviously, if you have done the PYQs, it is again a cakewalk question. The housemaid's knee, we have the pre-patellar bursitis. And then the second also, you should be knowing clergyman's knee. They are too famous. They are the infrapatellar bursitis. Okay, so if this was marked A, if this was marked B, that is marked C, or that is marked D, go with option number A. Being basically, you have to search out the pre-patellar bursa that might be inflamed in this, what we say is the housemaid's knee. Why is that? Let us look at the image. When the housemaid is doing the household chores over there, sweeping the floors, they bend more. When they bend more, the patella is the one that is actually striking the surface. But between the patella and the skin, there is a small bursa that might be inflamed. This leads to this pre-patellar bursitis. Understand the logic behind it. Clergyman's knee, which are the normal priests which are there in churches or other areas, when they kneel down, it is the part of the knee area that is, or knee region that is touching the floor is below the patella, and therefore this is the infrapatellar bursa which is involved, and therefore leads to infrapatellar bursitis. Understand this? So pre-patellar housemaids, infrapatellar clergyman's knee. Simple as that. Understand the logic behind it. Don't just cram or rot learn anything. Try to understand the simple logic behind things. Okay, another question. The ossification, the time of ossification. Right, so normally what happens is that you can say this question is a part of forensic question. Anatomy also we talk about ossification, but they're asking about the ossification time of the talus. Normally the talus ossifies around the 7th month. Around which month? Around the 7th month of the intrauterine life. So there are 7 tarsals, we all know. Only 3 tarsals are ossified before birth. So in intrauterine life, right, it is a calcaneum, it is a talus, and it is a cuboid. So these 3 tarsals are ossified before birth in intrauterine life. You can see in image, the calcaneum ossifies around 5th to 6th month of intrauterine life. Talus ossifies around 7th month of intrauterine life. Cuboid a bit late before birth, around the 9th month of intrauterine life. Remember these 3. Other tarsals, the cuneiforms, the navicular, they are ossified post-birth. Right? Here's an image showing us all these. This was the one that they asked this time. So be prepared about the talus is what they asked this time. So be prepared about the calcaneum, the navicular, the cuboid, the cuneiforms over here for the future questions. Right? So be prepared for that. Okay. So this was the question, and therefore answer is option number B. Though options are pretty close, but best bet over here would be the 7th month. Right. Let us see one more. A man is sitting and faces difficulty in standing up and in walking. Which nerve? So when we sit down and when you have to stand up. So when you're sitting down, our hip joint is in flexed position. Which joint? Hip joint. And when we stand up, our hip joint goes from flexion to extension. So which is the main extensor of the hip joint? The muscle over here will be the gluteus maximus, supplied by which nerve? That should be the answer, and that is supplied by the inferior gluteal nerve, and therefore this should be the answer. Now some students are also saying that scissoring gait, some question was given of that. Now normally scissoring gait, if you look at scissoring gait in medicine, scissoring gait is basically seen in cerebral palsies. Scissoring gait when you're walking and there's spasm of the medial compartment thigh muscles, and there's scissoring gait because their adductors are more, they're in spasm, so they are contracted in a contracted state. There's scissoring gait. Scissoring gait goes like this. That would be case of cerebral palsy, or if you can correctly frame the question in the comment box, you can have a look at that too. But if they only talk of the standing up from a sitting position, basically referring to what is the gluteus maximus muscle supplied by the inferior gluteal nerve. Scissoring gait basically should have some of the cerebral palsy cases that could be there, spasm of the medial thigh compartment muscles. Okay, do remember that. So let's see in the question. Yes, see, this is again an evergreen question. Anatomical snuff box. It seems to be like the paper is incomplete with unless they ask the question from this topic. Anatomical snuff box. I guess the boundaries they have asked. So we have done a multiple number of times, but again, just to recapitulate, the lateral boundaries of it are formed by the abductor pollicis longus, extensor pollicis brevis, and the middle border of this box is formed by the extensor pollicis longus muscle. And these two clinically, if their tendon sheaths get inflamed, we have the decurvent stenosynovitis. Decurvent stenosynovitis. Right? Let's see a couple of images. This is where we have the anatomical snuff box being labeled over here. This is the anatomical snuff box area. Medial boundary is this extensor pollicis longus, M for medial, and these are forming the lateral borders. Content is the radial artery, and at the roof we have the cephalic vein, the superficial branch of the radial nerve. Let us see one more image over here showing us the radial artery as a content of it. Right, as a content of it, these are tendons, and this would be the cephalic vein over here. This would be the cephalic vein, which is forming the line at the roof. This topic again just few days before the exam. Luckily, we were discussing this in a different sort of questions. Like this question we have discussed, pain on the lateral side about the decurvent stenosynovitis. Anatomical snuff box is what we have discussed over here. And again, we discussed on the fracture. I guess there some students were also saying the question came on the scaphoid fracture, some bone fracture over there. Again, that question we have discussed just few days before the exam. So these are so repeated topics that we now discuss. Then, according to the inputs we received, the image-based question came out the aortic aneurysms and having multiple episodes of hiccups and which nerve would have been involved. Some question was like this. Now look at this image, try to understand. This is a cadaveric image. The student said this cadaveric image was over there. Now this cadaveric image is taken on the left side. So this is the anterior aspect, that is the posterior aspect. The left lung and the pleura has been removed. So basically we are looking at the mediastinum from the left side. First of all, understand the image. Now, if you understood the image, in this region is the heart basically, and this thick is our arch of aorta. This is the arch of aorta. And here what we have, if I just outline a bit from here we have the structures lying at the root of the hilum of the lung. Okay, this also we have discussed multiple number of times, and here let me show you a few structures and let me write it over here. This will be the pulmonary artery over here, that will be the bronchus, these will be the veins over here, pulmonary veins. Right, fine. But the question was different. The question was asking about any nerve damage. Now see over here carefully. I am putting two arrows. One arrow is going over here and one arrow is going over here. Right, if we just zoom it, try to understand, I am putting multiple arrows to just show you the nerves. Right, you can judge yourself where was the arrow placed. And normally if they are asking the hiccups, they are asking about the diaphragm, the spasmodic contraction of the diaphragm. And the only motor supply of diaphragm is the phrenic nerve, no other nerve. So out of these, if we label this as A and B, you all should be very well aware which is the phrenic nerve. The A over here is the phrenic nerve, which passes in front of the root of the lungs. It also supplies the pericardium, the outer layer of the pericardium, sensory supply. And the nerve going behind this is the vagus 10th or the vagus nerve. Because behind you have the esophagus. This vagus nerve passes behind because it has to pass with the esophagus. Why? Because it is going to supply the foregut and the midgut, which include the esophagus and the stomach. Therefore, the vagus nerve passes behind. Now, if we talk of hiccups over here, as I already told you, we have discussed it. This is related to diaphragm, the motor supply of diaphragm. That is only provided by this nerve, that is the phrenic nerve. Now, vagus nerve can have some sensory supply to the diaphragm, but mainly motor supply, when we talk of it, it is only phrenic nerve. Okay, so just recall and try to visualize which question was asked. And this we have also discussed in our lectures. Just let me show an image over here where we have discussed this already, being the phrenic nerve and anteriorly vagus nerve behind. We have discussed them in details in our video lectures. Let's see, and the question, again a beautiful question about the maneuver over here. So in this maneuver, the sort of image might have been there. Language of the question might have been a bit different, but the essence of the question remains the same. They asked about the maneuver, which is actually being compression of the right margin of the lesser omentum, where we have this portal tride structures. So we have the portal tride structures, which obviously include the portal vein, the hepatic artery, and the common bile duct. And if you simply compress them, press them between your forefinger and the thumb, you are actually dividing the liver and the extrahepatic biliary apparatus with their blood supply. Right? And this maneuver, I hope we all must be aware of it, is known as the Pringles maneuver. It is used in liver or the EHB, extrahepatic biliary apparatus surgeries, when the bleeding is somehow not controlled. This is a Pringles maneuver, right? Now see over here, let me give you a rough idea what is actually happening. See, this is the esophagus, that is the stomach, right? And this is the duodenum. This is, imagine the lesser omentum going around. And here you have this as the right margin. This right margin is having the triad structures. So what is being done is that if you insert the forefinger or the index finger behind the right margin of lesser omentum, and the thumb, if the thumb is placed where? If the thumb is placed in front, right, can compress this right margin. Basically, we are dealing with which foramen? This foramen where your index finger is going behind the right margin of lesser omentum is the epiploic foramen. Epiploic or the foramen of Winslow. Epiploic foramen or the foramen of Winslow. This famous question repeated last. So again, a practical question has been asked. Understand, all of you are listening, understand how the trends are simply changing to a more clinical and more practical approach, which is actually for the good, right? So Pringles maneuver is what you should be knowing. It is a basic thing, right? We have the structure. Now see, the questions have asked, the questions are there for Pringles maneuver, the questions have been asked for epiploic foramen. Let me show you this. We have discussed about the epiploic foramen, the bleeding at the posterior part of epiploic foramen, answers IVCs, all this we have discussed. But understand, the question might also come around the arrangement of the structures. Where in this portal triad, we have said, okay, there are three structures are there: vein, artery, and CVD. How they are located? See, most posteriorly we have the portal vein in the right marginal lesser omentum. Covering it anteriorly and to the left of it, we have this hepatic artery. So this artery will be in front of the portal vein on the left side, and covering it anteriorly and to the right, this will be the bile duct. Understand the relations also in the this right marginal lesser omentum, that can be asked. So in the image also they are being shown over here, and this maneuver is a Pringles maneuver, right? Okay, a man suffered an injury on the head, and after this the blood collected around the eyes. Injury on the head and blood around the eyes. Again, a practical question, which I hope if you go to the OPDs of even the ophtho OPDs, you might see this, because person had a head injury or the minor head injury around a day or few hours back. Now he is seeing those raccoon eyes, black eyes. He will rush, the person, normal person will rush to the ophtho department, right? So if you go to the OPDs, you will see this. They're asking you what is leading to all of this. That is the question. Where is actually the bleeding? Because the injury happened to the head, injury didn't occur around the eyes, the primary injury. So this is basically a question from the anatomy of the scalp. The bleeding is actually happening where? The bleeding is actually happening around the epineuritic or subepineuritic bleed. So basically around the epineuritic attachment would be the best bet out of these options, or they can also subepineuritic region around the loose areolar tissue layer, subepineuritic layer. Now see, understand the anatomy over here, a bit anatomy over here. What is this? Everything has a meaning behind it. We have the skin outside. Deep to the skin, what we have? We have this connective tissue. Again, it has a lot of septas, nerves, vessels, all of it. Deep to the connective tissue, what we have? We have the epineuritic layer. So this will be the muscle layer, right? Muscles, frontalis and occipitalis, and joining them will be the epineurosis over. This will be the epineurosis over here. Deep to it, what will have? We'll have the loose areolar tissue over here. And deep to it, what will we have? We'll have the periosteum layer over, which is actually fused to the skull bones again. Right? Now see what happens is this frontalis muscle over here. This frontalis, if we consider this as the anterior aspect and this as the posterior aspect, this frontalis muscle over here is fixed to the upper eyelid muscles. If you elevate the upper eyelid, you see some horizontal pieces over here. Frontalis muscle and the LPS, they are working in tandem, right? So therefore this frontalis is glued to the upper eyelid, right? If the bleeding is occurring somewhat over here, so slow bleeding starts over here at the injury to the head, this blood will slowly trickle down in this direction, and then the loose skin around the orbit, the blood will start to collect over here, black eyes. Now you might ask a question that, sir, why the blood does not go laterally, why does not go posteriorly? Because if you look at the basic anatomy of the scalp, once you look at all those lectures, the layers over here are fused to the lateral and the posterior aspect. At the nuchal lines, they are fused to the bones. On the sides, they are fused to the temporal lines and the zygomatic arches over here. So they can't go, but here they are fused to the skin at the upper eyelid. So the blood can easily trickle down. That is leading to this question, this answer. Here's an image showing us a simple black eye. This is a minor case. Sometimes cases are there when everywhere over here we have the collection of blood, right? Okay, so these were the questions, and then again showing you a few screenshots, because I have heard the question came around the humerus fracture also, and asking you which nerve was damaged. So you can see the question we have just discussed few days back, that there was a fracture of the mid shaft part of the humerus, and again this nerve and this deep brachial artery is injured. So these are all few days back. So just to motivate you to look at those YouTube sessions, even high speed also, try to attend live, because you can ask the questions directly with the faculty over there, and the main video lectures as well. This question also we have discussed just few days back, and same thing. The humerus is shown, the fracture is being identified, and which nerve is being damaged, again radial nerve, right? So these sort of questions have been come, and we have luckily been discussing them. So go through all the subjects about the lectures. And I guess we also heard about a question came from the craniorachis, right? So that is basically part of embryology, neural tube defect. So neural tube defect, when there is a non-closure of the neuropores, normally we should be knowing that the neural tube is there, and they have two neuropores, an anterior neuropore and a posterior neuropore. It closes around day 25, and this closes around day 28. They don't close. If the anterior neuropore doesn't not close, there's an anencephaly. When there's less development of the skull bone, the brain is underdeveloped, being exposed outside. Obviously, the child is not viable for birth. Okay, it's non-viable, is a stillbirth baby. And when that closure goes down posteriorly as well, or inferiorly as well, there's opening of the spinal cord with the CSF lying outside. That is what is known as a craniorachis, combination of all these layers which are not able to close. That is again a neural tube defect, and I hope, due to the feedback we received, that some image-based question was there. So I hope this was the question, and craniorachis would be the best possible battle, right? So guys, that was all, and again I am telling you that relax, exam is over, right? For all those who have given the exam, understand these are topics, note it down, because they don't relax too much. Note it down, the topics. If you will be clearing, and I hope you will be, then these are the topics for the future exams. And for those who are going to give the exams, understand the type of questions, and all the best. And do also understand that, because before the exams, few days back, when we are doing the sessions on YouTube and all, these are very fruitful sessions, as we've seen over here, right? So that's all the best, and thank you.